let's talk about the bispecifics, because it's talking about logistically. I mean, that it's expensive. They are customized products for each person, unless you're going to come up with a universal cell. So, Sonny, the bispecifics are attractive, right? Because you're engaging the T cell, you're bringing it right in juxtaposition to the lymphoma, forming the synapse. What are your take on that?
Well, I think intuitively it makes a lot of sense, particularly if targeting CD3 can activate the T cell. I don't pretend to think that it's that simple, but I do think that bringing the cells in proximity at least allows a chance for that type of immune attack to occur. Most of the bispecific antibodies have targeted either CD19 or CD20 on the B cell and then CD3 on the T cell. And, I think there are some unique toxicities to the bispecific antibodies. I think the administration route may be a little bit challenging for low-grade lymphomas. So, from my perspective, it's a little early to really think about where bispecific antibodies might fit into an indolent disease.
Yeah, I think we definitely need more trials. There was an abstract at ASH looking into some of the early BITE data in large cell and in follicular, and the concerning thing is, as Sonny mentioned, you saw these same toxicity profiles that we see with CAR Ts, really cytokine release syndrome, you saw neurotoxicity. So, and I think Josh brought this up, I think we need to really build a better, safer product before these kind of drugs can move into a low-grade type disease.
And then kind of in the middle is the antibody drug conjugates and polatuzumab vedotin. There are several others. I can't pronounce all their names, but I think they clearly have activity when you have an antibody drug conjugate, depending on whether or not there's an immune effect or if it's just the drug delivery mechanism with a more targeted chemotherapy. These are all active. Certainly a number of them have response rates in the 30 to 50%. They seem to be studied a little bit more in the aggressive lymphomas, I think more for practicalities that bring them forward, but they're also active in follicular lymphoma, and we'll see if they make it, get any traction as far as any sort of comparative studies there.
I was surprised at I thought the dark horse at ASH, the one that people may have walked by, was the POLA BR versus BR and relapsed refractory large cell. But then to see at ASCO this year that the follicular lymphoma didn't look as good as, I was scratching my head when I was reading that abstract, because I thought that, it would be maybe even look even better, but I guess it's going to be in the details.
Better chemotherapy or more effective chemotherapy in follicular, probably.
So, I mean, one of the problems with some of them has been the neuropathy, but the POLO, the alternative dosing scheduling, I think has really made that easier to give in patients with follicular lymphoma. We'll cut way back on these patients with low-grade malignancies. Of course, you wouldn't want to leave them with a terrible, devastating neuropathy. So, but I think that's gotten a lot better. Now, Nathan, what about some other novel therapies for patients with follicular lymphoma? John touched upon acalabrutinib in the refractory setting in patients with follicular lymphoma, but you've done some work with acalabrutinib in follicular lymphoma. Where do you see that looking like?
Yeah, so as John mentioned, there have been a couple studies now that have looked at acalabrutinib in the relapse setting in follicular, and one recently published showed a response rate only about 20%. So I think the drug, at least as a single agent, doesn't have a lot of activity, or doesn't have a real role in follicular lymphoma, at least with other agents that are available. But we have seen some preclinical data that acalabrutinib may change some of the phenotypes, or actually have a switch towards different levels in T cells within the microenvironment. And maybe using a drug like that could help or augment the effect of rituximab. And so we did a couple trials with acalabrutinib and with acalabrutinib combined with rituximab in the frontline setting. And interestingly, in both of these trials, we saw responses around 80 to 90%. Now, again, this is frontline with rituximab in a patient population. Some of these patients did not need treatment. It's hard to know how much of the effect was just Rituxan alone. In the acalabrutinib trial, we saw a CR rate of around 50%, and in the acalabrutinib trial, we saw a CR rate of around 30%, which, again, comparing across trials, but the CR rate is maybe a little bit higher than you would expect with Rituxan alone. I think that it's going to require larger trials to really understand what this means for follicular, and one of those trials is currently enrolling. It's called the prospective trial, and this is in elderly patients with follicular lymphoma, ibrutinib rituximab versus rituximab, and basically in patients who would not tolerate chemotherapy.
Is there any bizarre etymology to perspective that we didn't know about for the naming of that?
Did you come up
trial?
with this one?
Did you come up with that one?
Perspective. Give me a minute.
Okay.
I'm not, no.
Every third letter.
Yeah. I mean, I think that it's at least exciting to be open-minded about the difference between ibrutinib and acalabrutinib. There, ibrutinib, we had, I think, a lot of concern in the beginning. It hits ITK at IC50s just above BTK, so it not only affects T cells, but certainly hits NK cells, which are ITK dependent. So in theory, there was a concern about worsened ADCC. Stanford group published a preclinical paper, in vitro effects of ADCC with ibrutinib, but acalabrutinib does not hit ITK at all.
Well, it's interesting, and then that same group published another paper a year later saying there was synergy between anti-CD20s and ibrutinib. So I think
Let's agree it's an excellent group.
yes. Well, I just think that what that tells me is that the field is in flux, right? And we're still learning about how these drugs work.